today or other places where, you'd expect a nurse to come in and be able to fill a syringe, and that's part of the training, and you get the bubble out, and you put the, everybody's seen it on television if you haven't seen it in person where they're, getting the, well, actually, you have to be trained to do that. And actually, it's very important to do it well because if you have an air bubble that can kill somebody. So, it's not an insignificant training. So we said, why could we actually solve for that by taking, by doing what we call task shifting. Shift that task to a lower trained person who can then do that instead of taking all the time of the nurse who should be attending to other higher, more important things than from filling the syringe, as an example. So we do a lot of work thinking about shifting the task, enabling somebody that's not as well trained to do the work because we don't have enough of those trained people in a lot of the places that we work. And so we created this little, I should have brought one, a little plastic bubble. I mean, it's pretty simple. You look at it and go, God, I could have thought of that. I mean, it's a plastic bubble. It's about this big, and it has a little pin, a needle on the end of it. And it's, you fill it, and you literally go boop and squeeze it, and it's like getting an injection. But because it's pre-filled with the plastic bubble, you don't have any of the concerns about filling the syringe. And you could do this, or I could do this, or my mom, my 90-year-old mom could do this, because it's that simple. So that's actually been a real lifesaver to figure out how to do that. So we also then looked at one of the big problems in the world is women in many parts of the world where we were have very restricted access to family planning tools, and they actually are asking for them. They want them, but there's a defined 200 and 250 million women in the world, and an estimate that Melinda Gates and David Cameron went out a few years ago and made a big commitment to say, we need to start addressing more directly this fact that there's a quarter billion women in the world that are wanting family planning tools, and they don't have access to them. So there's this unmet need. These are voluntary family planning. And so we've been trying to help with that problem, saying, what can we do to make this easier for women who might not be allowed to go to a clinic, or their partner or husband won't let them use family planning, but they want to use it. And so we actually said, well, what if we took that vaccine tool and worked with a group of industry that makes a long-term injectable family planning contraceptive, and mix those two, put them together. And then so women could then inject themselves with a long-lasting injectable contraceptive. And that's actually something we tested, we put together. We've now seen it rolling up, and hundreds of thousands of women are, in the last 2 years, are getting family planning tools for the first time in their lives, and wanting those in rural communities all throughout, like Nigeria and Ghana and Uganda and that part of Africa. So those are the kinds of, that's a game changer. It's much more effective. It will see a lot of people having more sustainable solutions. And it was sort of taking frugal technology, doing a bunch of business deals to get the right things put together, and now making sure it can be rolled out and be integrated into the health system where we're working. Diagnostics, self-explanatory, really big need in the world. I've been in many places in the world holding babies that are dying and die because they have been diagnosed with the wrong disease. People say, oh, they have a fever, they must have malaria, we'll put them on malarial drugs. We didn't test them to know, there were no tools available to test to know it wasn't malaria, it was an infection, and if you just treated them maybe with some sort of antibiotic, you could have saved the baby's life. This happens every day, over and over and over. So we're working on how do we develop better, cheaper, simpler diagnostics that can be now with remote technologies, can be remotely read and used. So a lot of great work there. And then I've mentioned we do hundreds of devices, everything from family planning tools to maternal child health tools to vaccine delivery tools and more. And then the biggest part of our work actually is in what we call system and service innovation, which is a mouthful. But what it means is it's not enough to just have a product. You have to think about how the product's going to be used and what the system issues are, and how to actually maybe think about operationalizing the way and working with countries to operationalize their approach differently. So let me give you a very quick example of what this looks like, and then close out. In Zambia, which is southern Africa. A decade ago, in some of the regions in southern Africa, in Zambia, 1 out of every 2 people had malaria. So think of that in this room. You or your neighbor would have had malaria, and most everyone would know somebody in their families died of malaria. Today, just a decade later, that's about 1 out of 200 and getting better. So one of the major things is coming in, working with the government, some of our folks, some other folks, sat down and said, let's take a different approach to controlling this disease. And big thing that happened was you could now use cell phones to track every case of malaria real time. And then using some topographical data that you could integrate into that model, know how far likely around that case you would have infected people or parasites. Because the thing is the problem with malaria, it's like an iceberg. Actually, only about 20% of people who have the parasites that cause malaria through mosquito bites, only about 20% of them ever have a fever or symptomatic. And what we do, and traditionally do, is just treat the sick people. But if you think about that, if you're only treating the 20% at the top of the pyramid, you're leaving this reservoir of parasites that is just in the community, and then the mosquito comes to bite you, and then you go to the next person, and then it just keeps going on and on and on. So we said, let's not focus on the symptomatic sick people, let's focus on eliminating the reservoir, getting rid of all those mosquitoes, anybody that has the parasite in, once you get the parasite out. We know how to do that. We can treat people to get the parasite out of their body. And so what we did is, so using a cell phone, I wish I put these slides up, you can actually map, here's the village, here's the community, we now have micro maps of every community, and then if we see there's an outbreak, we test everybody in the radius that a mosquito would fly. It's about 100 meters, just ever wanted to know that going camping. That's about the flight of your average mosquito. And then everybody gets treated for the drug to get rid of them and parasite. And we've seen in those regions of Africa, we've seen an 85% reduction in malaria cases in just 3 years using this model. So that's an example of saying, wait a minute, it's not just, there were no actually new tools. I mean, yeah, the cell phone was, but it's not like we got a magic new drug or the new vaccine or anything. This was just simply saying, let's do the process different. Let's reinvent the design of the process. Let's work with government to help them, support them in figuring out, and let's test it and get the evidence, and if the evidence is working, then we can scale it up. So these are the kinds of things we're working on. So, I could go on, and I won't, with the kinds of, I've mentioned a few of these, the kinds of examples of the programs that we see around the world. I'll just end with the one example just to underscore the idea of partnerships. So there's a meningitis. You guys, I'm sure, on a college campus have talked about meningitis because it's a very scary thing. There's a strain of meningitis which for centuries had rolled through Africa called meningitis A. And it was literally, the studies would show, was the most feared thing in a parent's life. More than malaria, more than birth, risk of birth. It's because meningitis would kill a lot of kids. But if it didn't kill them, they would be neurologically damaged so badly, and sometimes physiologically damaged, that they were like, it was a huge burden. I mean, these kids were non-functional. And then those have compounding effects. Then the whole community is affected, and the family and the community. And so it was a feared thing. We've actually developed a vaccine for meningitis A and other strains of meningitis and use them in the rich world. But in parts of Africa, we were seeing this every year, and finally a number of African leaders came forward and said, enough already, we need a meningitis A vaccine, because this is a horrible vaccine, and somebody knows how to do this, horrible disease, because and by the way, we know how to develop it, and we have one already, it's just too expensive, it's not for the right strain. So Pat took that on with support of the Gates Foundation and others, and we're the Gates Foundation's largest partner. And we actually worked for a number of years to develop a new vaccine for meningitis A. But what was interesting about it is that it wasn't, two things. One is that it was mainly, the agenda was mainly driven by African leadership. So this wasn't a, let's just, come up with something and then throw it over the fence and, use it in Africa. This was like, African leaders were at the table, setting the requirements of the product, engaged every step of the way. And it's the first ever vaccine developed specifically for the African continent. And then what we also did is said, look, we've got to start developing things in a way that is more cost effective. So this isn't a matter of, let's just take something that's really expensive and then, sort of get a subsidy and discount it. It's like, we got to have this as cheap as possible. So we actually put in the scientific target profile of the product. This had to be less than 50 cents per dose, which is a very small amount of money for a vaccine. And so, long story short, and it was a very long story, we've actually developed that vaccine. We enabled it to go to the public markets. It's through partnerships, an Indian manufacturer. And what's amazing about it, we've actually seen 300 million people, that's a lot of people, that's more than, about the US population. 300 million people now have received the vaccine. Nobody has gotten sick after they've seen it. And we've effectively eliminated this disease from this part of the continent. And we are now trying to make sure that we can get other strains of meningitis. But it's the kind of scale effect of innovation. If you do social innovation well, you can both create new mechanisms, models, prices, financial incentives, but also imagine scaling